Okay, welcome everyone. Assalamu alaikum. My name is Maryam Altayeb. I'm just making sure you guys can hear me. So my name is Maryam Altayeb. I'm a fifth year medical student. And today I'm going to be teaching you guys about electrolyte disturbances and acid-base balance. So first of all, as a disclaimer, if you see anything moving in the background, those are my cats. So I hope you enjoy having that little distraction. So I know acid-base balance is a very big topic. It's very daunting. A lot of people hate it with good reason. It's very complicated, and I tend to find that particularly when we are taught this in medical school, it's a lot more complicated than it should be. And it can be a lot easier. So I'm going to try my best to guide you through it and make it as simple as possible. Okay. Cats, yes, definitely. Most important thing, academic aid. I don't know who you are in academic aid, but happy to have you here. All right, so I'm going to basically start by explaining to you guys what are electrolytes in the first place. Why do we need them? We're going to talk about each electrolyte and use the LGD case as an example for hyponatremia. Then I'm going to give you a document that I made 2 years ago when I was in third year as a general algorithm for acid-base balance. And through that, we're going to go and take the LGD cases as well and go through everything with these rules in mind. So inshallah, by the end of this, you guys are going to understand acid-base much better. And I hope it will be, easier, so to speak, topic to digest. Okay, so first, it's going to be a long lecture. I tried to keep mini breaks in between just to keep you guys fresh. And but first and foremost, get energized. Make sure you have your water, your coffee, if you're daring to drink coffee at 7:18 p.m., depending on how sleep deprived you are. So now let's firstly, to get into this talk about fluids in the body. So fluids are divided into different compartments. So you have non-water body mass, so that's, your tissues and cells and whatnot. And then you have your total body water, which is approximately around 60%, but it's going to differ based on the person you're talking about, male versus female, older versus younger. But this is the general distribution that we tend to look at. And within the 60% total body water, we know this, and hopefully from first year, you guys remember that part of it is extracellular fluid, which means extra, outside the cells. So this would be divided into our interstitial fluid, which is the fluid that's actually around the cells, and plasma, which is the fluid that is in our blood. And then you have your intracellular fluid, okay? And so 10% of this is ICF and RBCs, or red blood cells, and the rest of the 90% is in the tissue. So you can see how 40%, a lot of this intracellular fluid is already within our tissues. And within this distribution of intracellular fluids, you have different ions. You have your sodium, potassium, calcium, magnesium, etc. But the two main ones that we're going to be talking about today are sodium and potassium. What I want you to keep in mind from now is first the distribution that we talked about, right? Intracellular fluid is around 40% of your body weight, okay? And extracellular fluid is around 20%. That's what we just saw in the previous slide, all right? And so what's very key for us to know here is potassium is higher intracellularly, or inside the cells. So you can see here it's 110 millimoles per liter. But on the other hand, sodium is 140 millimoles in the extracellular fluid. So you can see how sodium is more concentrated in the plasma. Okay, however, in the intracellular fluid, potassium is more concentrated. And this is going to come to be very important when we look later at the different things that can happen pathologically. So what we're going to do, all right, so what I want you guys to remember, and again, these are very basics. I'm not saying anything new here. I just want to reiterate these things so that you guys keep them in mind. These ions, so potassium from the inside of the cell and sodium and a bit of potassium from the outside, are always shifting, and they're shifting based on the fluid compartments. I'll show you what this looks like in a second, okay? But so we know the sodium-potassium pump, or ATPase, right? You need ATP for it to be activated. That gives you 3 sodium outside for every 2 sodium inside. So this helps to keep this gradient between the cells, okay? And that's active transport. And then you have passive transport, which is just passive diffusion of sodium and potassium across the membranes. Okay, so in this case, you can see it as across the capillary wall. So capillary is the smallest unit of our blood vessels, and that's what penetrates our tissues. Okay, so this is, again, just to revise a very basic concept, but when we talk about electrolytes, it's these ions that we're looking at. So potassium, sodium are the key ones for today. And so this is what Dr. Khalid Al-Amri included in his slide. So it's basically what we just talked about. So we know total body water is 60% our body weight, mostly intracellular inside the cells, and extracellular. He says that the movement across the cell membrane depends on Fick's law, which is what I just showed you guys here, this passive movement of ions, okay? And so this is how water is going to move by Fick's law across, and the way water moves is going to be dependent mostly on sodium, which you're going to come to see. So, you guys remember osmosis and all that stuff. So wherever you have a more concentrated area, you're going to have passive diffusion onto that place. So that's what we're talking about when we're talking about Fick's law. When you talk about the Starling equation, so Starling equation is essentially looking at the pressure. So this is how fluid is going to move across from the interstitial fluid into the plasma. Okay, so this is just so you guys get a better understanding of the slides that are included. Just so you know, I included all the slides that Dr. Khalid had. I just added a few things here and there to make it easier for you guys to understand. Yes? You care to join us? Okay, my apologies. So a term that you're going to see thrown around a lot is osmolality. So what is osmolality? Osmolality is basically a measure of concentration, and it's primarily dependent on sodium. You're going to see two terms mainly. You have serum osmolality or plasma, okay, which is the plasma we just talked about, right? The fluid that's in your blood. And then you have the urine osmolality, which is basically how much sodium is in your urine, how concentrated is your urine, and vice versa, how concentrated is your blood. And the reason it's primarily dependent on sodium is, as you can see, this is the equation. So 2 times sodium plus BUN over 2.8, which is blood urea nitrogen, and the glucose level over 18. So essentially, if you put in all the normal values of this, you're going to see that the value of sodium is going to determine the osmolality the most, which is why we say it is the most important in terms of determining your concentration. Like I mentioned to you guys previously, it's also very important for us to grab water from one area of the body to another. For example, if you have very high sodium in your blood, as a response, what your body is going to do is it's going to shift more water into the blood in order to normalize this. Because as we know, the body is always functioning to maintain this type of homeostasis. We want to keep everything equal and balanced in the best way possible. Okay, so these are the general serum osmolality values that we want to look for. So 285 to 295 milliosms per kilogram of water. So this is the general range that we're looking for. Anything below, okay, or anything above, as we'll see in a moment, is going to be hypo or hypernatremia. Why natremia? Well, natrium is the old word for sodium in the periodic table. That's why it's Na. So remember, it's primarily dependent on sodium. So that's why when you look at the serum osmolality, the changes are going to determine whether it's hypo or hypernatremia. So this is a key thing that I wanted to show you guys. So these are the intracellular and extracellular compartments that we talked about before, right? So you have water moving in and out. If you have increased ECF osmolality, so high osmolality in the plasma, what's going to happen? Your body is going to draw water out of cells, out of the ICF and into the ECF in order to keep that balance. But consequently, what happens? Your cells are going to shrink. Okay, so you're going to have dehydration of the cells. And this is going to be important when we look at hypernatremia, because in hypernatremia, it's essentially true dehydration. You're dehydrated, so your fluid, your plasma is very concentrated, so your body starts to draw from the inside into the blood. Now, what if we look at decreased osmolality? Well, that's going to be the opposite. If it's very diluted here, this becomes the more concentrated area. So water by passive diffusion is going to move into the cells, and that's going to cause it to swell. So this is going to give you cellular edema. And this is very important when we talk about hyponatremia, which we'll see in a few slides. What can happen is in very severe hyponatremia, you can start to have swelling of the brain. And as you know, your brain, your skull is quite solid, right? So it's made that way. So what happens is, let's say you get cellular edema in the brain, it starts to expand, but it's expanding in a closed space. So when it expands in a closed space, you guys remember from neuro, that can cause uncal herniation or herniation, depressing the brainstem, and that can cause the patient to go into a coma. And that's going to determine a lot of the clinical features of hyponatremia, especially if acute, which we'll see in a moment. So I don't want to get too ahead of myself, but I just want you guys to understand this at a cellular or fundamental basis. So now hyponatremia. There's different ways to classify it. There's true or pseudo, which we'll talk about. There's acute, there's chronic, symptomatic, asymptomatic, etc., etc., etc. So there's a lot of ways to look at this, but let's take it step by step. First, what is hyponatremia? Hypo means low. Natrium, coming from, the old word for sodium, like I told you, that's why it's called Na on the periodic table. Okay, and emia is presence in blood. So low sodium presence in blood. Excuse me? It's not the time to meow. Okay, I'm sorry. So less than 135 milliequivalents per liter of sodium in the serum. So the normal is 135 to 145. So less than 135 is hyponatremia. So essentially what this means is that there's too much water in the extracellular compartment. So you're diluting the blood. So you have either too much water or you have too little sodium. Guys, why are you fighting? Peppers, let's go. Gosh. Maybe it wasn't such a good idea to have this lecture with cats. Anyway, so hyponatremia, low sodium presence in blood. And so what I'm going to do is just going to look, this is from Imbalance, by the way, this image. So show you guys generally what it means, hyponatremia. What I want you to see specifically are these severe symptoms that usually happen in acute hyponatremia. So there's stupor or coma, seizures, ataxia, respiratory failure. And remember, all these things are correlated with the degree of cerebral edema. Guys, give me a second. I'm going to get my cats out of here. 1 second. It's left building. Sorry about that. Anyway, okay, so again, to define hyponatremia, it's low presence of sodium in the blood, less than 135 milliequivalents per liter. Okay, if it's an acute in onset, it's less than 48 hours. And usually these patients will show more severe symptoms. And the reason you have these symptoms is because of, remember, if there's low sodium in the blood or you have a hypoosmolar state, what's going to happen is the inside of the cells are going to be more concentrated with solutes. Okay, so the water is going to go from the plasma into the cells. And the problem is in the brain, it's in a closed cavity, so it's going to cause cellular swelling. Okay, and basically edema. Mild to moderate symptoms, again, headache, dizziness, forgetfulness, malaise, can also cause nausea and vomiting, as well as muscle weakness. All right, and we're going to go through all the other points, diagnostics and whatnot in a bit. So like we mentioned, hyponatremia is due to water shifting, or we have something that we call pseudo-hyponatremia. So this is the normal state where you have a balance of electrolytes from the inside to the outside. Okay, what happens in something that you call hypertonic hyponatremia? We said before, osmolality is primarily determined by sodium. So if the osmolality is low, you expect your serum to be hypotonic, right? That makes sense because there's no sodium. So in a case of hypertonic hyponatremia, what that means is there's something else that we didn't account for. There's another ion in the blood that's causing it to become concentrated, but that is not sodium, it's something else. So for example, you can have hyperglycemic states. So someone with diabetic ketoacidosis, someone who's been treated with mannitol. So basically what happens here is you have too many ions, you can see them here, but none of them are sodium. So you get hypertonic hyponatremia, okay? And then you have hypotonic hyponatremia, which is true hyponatremia, all right? So in all these cases, the serum osmolality is low and you have hyponatremia. So both of those two go hand in hand. Okay, so there are all these three states, all right? So one example is you have a decrease. And so what happens in a decrease is a true hyponatremia. You have very little fluid, you're losing too much fluid. And so when you lose that much fluid, then you're also going to lose, and you can lose sodium, and that can cause our hyponatremia. If you have an equal amount, okay, so hypotonic hyponatremia with a normal sodium, this can be due to SIADH. So SIADH means syndrome of inappropriate ADH secretion. That means you're losing too much fluid due to excess antidiuretic hormone for one reason or another. And the reason sodium is normal here is because the body has a compensation mechanism via aldosterone. Okay. And then lastly, you have hypotonic hyponatremia, but you have more volume, you have an overload of fluid. Okay. And when you have an overload of fluid, basically the problem here is what we call a perceived hypovolemia. For example, patient has nephrotic syndrome, or maybe a better example is congestive heart failure. Okay, so this patient has a congestive heart failure. So because there's a heart failure, the heart is unable to pump properly. However, you have a lot more fluid in the body. And the reason that happens is the capillaries are underfilled. So when the capillaries are underfilled, your body thinks there's hypovolemia because, the ends of the receptors are not receiving enough fluid. But it's not really hypovolemia. It's just that the heart is not pumping properly enough. Or with cirrhosis or nephrotic syndrome, all of the fluid is escaping outside because you don't have enough albumin. And so what happens is you activate the RAS system, you start reabsorbing more water, even though you don't need to reabsorb more water. So you basically get a dilutional hyponatremia. Okay, and so these patients tend to be hypervolemic. There's too much volume. Sorry. In case of SIADH, remember the body's compensating. So they tend to be euvolemic, meaning their physical exam is normal, there's no congestion. And in cases of diarrhea and vomiting, they tend to be hypovolemic or dehydrated. Okay, so this is basically what we just talked about. You can divide it based on your volume status. Like we talked about cirrhosis, congestive heart failure, nephrotic syndrome, these are hypervolemic causes of hyponatremia because you have, again, underfilling of the capillaries, activation of RAS. Okay, in euvolemic states, that's usually SIADH, hypothyroidism, and Addison's disease. And hypovolemia, again, can be renal or non-renal, can be due to acute kidney injury, treatment with diuretics. Specifically, thiazide diuretics are notorious to cause hyponatremia. And non-renal causes are what we just looked at. Diarrhea, vomiting, burns, because when you have a burn, the outer layer of the skin is unable to keep all the water intact. So you basically are losing a lot of water and electrolytes and whatnot. And SPO as well. Okay, so this is just a general algorithm for looking at it. Now we look at how the body is going to respond to that hyponatremia. So in the case that we just talked about, let's say you have decreased arterial pressure and increased osmolality. Okay, so what that's going to do is that's going to increase our vasopressin. That's going to activate two things. So first, you're going to have activation of the receptors, the V1A receptors, which cause vasoconstriction. And the V2 receptors are going to act on the tubules to cause reabsorption of water. Okay, and so that is a case of increased osmolarity and decreased arterial pressure. Okay, you can also have it with decreased osmolarity, and increased arterial pressure. Okay, so basically the body is trying to come with a way to compensate or balance for the changes in the electrolytes. And so this is another view of how the kidneys are going to respond. So if you have activation of RAS and sympathetic nervous system, you're going to have increased renal tubular sodium absorption, right? Because when you have RAS, you're going to have increased movement of renin, angiotensin, aldosterone system. So aldosterone reabsorbs water, sodium, and water goes along with it. And when that happens, when you have activation of RAS, you're going to have low urinary sodium. So, for example, in the example of congestive heart failure that we had, you'd expect the serum sodium to be low because your RAS is activated. Okay. However, when we look at vasopressin is antidiuretic hormone. We're mainly looking at the aquaporin channels, and you're going to increase your urine osmolality because here you're mostly absorbing water. Okay. And so you're decreasing your water excretion. So in these cases where you have high ADH, for example, like syndrome of inappropriate ADH secretion, what you're going to expect is you're going to expect very concentrated urine, right? Because your vasopressin is very high. In cases where your RAS and sympathetic nervous system are activated, you're going to expect low urinary sodium or low urine osmolality because here you're absorbing more sodium. Okay, so I hope this makes sense for you guys. And again, if you have any questions, just feel free to let me know in the chat. Okay, so now when we look at hyponatremia, first we looked at the serum sodium level. Is it actually hyponatremia? And then serum osmolality. Remember, it can either be hypo, which is the true hyponatremia, or high, then it's pseudo-hyponatremia due to either high levels of proteins, high levels of glucose, etc. Then what we just talked about, you're going to look at your urine sodium level and you're going to look at your urine osmolality level. So do these match? For example, if you have serum osmolality is low, serum sodium is low. Okay, so we know it's hyponatremia, right? And serum osmolality level, as per this, for example, is also low, then you'd think, maybe I have activation of the RAS system. This can possibly be the causes that we talked about before. So congestive heart failure, cirrhosis, nephrotic syndrome, right? However, if it's the opposite, if serum sodium is low, serum osmolality is low, but urinary sodium and urine osmolality are very high, your urine is very concentrated, then you're going to think, maybe I'm reabsorbing too much water. So that would be, the clinical clue for you to start thinking about syndrome of inappropriate ADH secretion. And we'll talk about the causes of that in a minute. I just want to make sure that with the pathophysiology, you guys understand what can go wrong and where and why, especially because these labs tend to be very confusing and you see osmolality thrown around like 100,000 times. So I just want you to make sure that that's clear. Okay, and so you understand the basics of it. So even if you're thrown a question, you know how to answer. So this is again what we just talked about. So hyponatremia, okay, with high urine osmolality. Okay, if you have low urine sodium, it can be due to low perfusion. So low perfusion is what we just talked about. So heart failure, cirrhosis, GI loss, essentially the kidney is not getting enough. All right. If you have high urinary sodium, so high perfusion, you start to think of SIADH, hypothyroidism, Addison's, etc. Now, hyponatremia with low urine osmolality. So when we say hyponatremia with low urine osmolality, you're basically looking at it in a sense of, okay, I have hyponatremia. My body is not compensating. And so these causes are actually quite interesting. So either you're peeing too much, okay, you're urinating way too much. So what we call that is polyuria. So you have a very high urine output. So here we start to think, okay, maybe there's diabetes, whether it's diabetes mellitus because of the glucosuria, whether it's nephrogenic diabetes insipidus. Essentially, you're urinating too much, you're losing too much water, okay? And you can have something called beer potomania or tea and toast diet. Basically, in these cases, you're not taking in enough sodium. Your diet has sodium that is so low that you're getting hyponatremia, okay? And then you can also have this due to renal failure. So you have low urine output, but high urine sodium. And renal failure is a very complex topic. I'm not going to touch on it as much. I just want you guys to be able to differentiate these two things based on the osmolality of the urine. All right. So this is what we talked about: ADH dependent. These are ADH independent. And those are the key distinguishing factors. Okay. And this is going to be important as well when we talk about our case. So now we look at acute or chronic. So acute hyponatremia, remember, anything acute is usually more severe in medicine. So this is when you start to have the really bad symptoms of patient can be disoriented, confused, they can start having seizures, going into comas, all of the really bad things that you associate with hyponatremia. However, when it's chronic, your body has the time to compensate. So in case of chronic hyponatremia, you might have mild to moderate symptoms depending on the degree. So how low is the sodium, essentially, and how long has this been going on for? So this is what I was trying to show you guys. When you have rapid onset of acute hyponatremia or rapid correction, so too much fluids, what happens is you get very fast decrease in the serum plasma sodium concentration, right? And so what happens is cerebral edema. And you can see the uncal herniation here. So this starts to compress on the brainstem, decreasing respiration and causing all those symptoms because, again, your skull is not going anywhere anytime soon. It's a very rigid structure. On the other hand, if you have as well rapid correction of chronic hypernatremia, okay, and rapid onset of acute hypernatremia, what that can cause is osmotic demyelination, or if you guys remember from neuro, what we call locked-in syndrome. So locked-in syndrome or osmotic demyelination, also called central pontine myelinolysis, is you can see here in the pons, essentially you get demyelination of all the neurons here. And what happens is the patients get paralyzed completely, and the only thing that they're able to move is their eyes. So if I'm not mistaken, up and down and horizontally. And so that's how they're able to, communicate. So when you treat hyponatremia, it's very important to be cautious of this point. You have to be very diligent with the way you're increasing the sodium. Otherwise, you can cause the patient to be paralyzed as such. So that's what we just said. So treatment in acute or severe symptoms, and keep in mind, acute or severe, you don't want to treat everyone with hyponatremia. Because, for example, if the patient is hyponatremic because of diuretics, okay, we can wean off the diuretics a bit, or we can replace it with another diuretic. But because of the risk of osmotic demyelination, you want to be very cautious and sparing with your use of hypertonic saline or 3% normal saline, which is the treatment, right? If there's not enough sodium, give water with more sodium. And in chronic or asymptomatic, so you have different things that you can do. So water restriction, diuretics, salt tablets, etc. So target increase between 6 to 8 milliequivalents per liter per day. For both of these, you want to be very cautious about how much you're increasing. All right. So that's hyponatremia. Now I'm going to go through this algorithm. I added a lot of tables that I found helpful from New World. So this is what you need to know. Patient has hyponatremia. So you establish that sodium is low. Is your serum osmolality high? If it's high, then you know it's hypertonic, right? Hyponatremia. So here you're going to see marked hyperglycemia, so DKA, can also be seen in advanced renal failure, right? Remember we said renal failure is very complex, can give you a lot of different presentations. Okay, serum osmolality is not high, it's low. So now we know it's a true hyponatremia. So what do? We look at the urine osmolality. If urine osmolality is also low, so basically you have low sodium, low serum, and low urine, then you know, okay, this is a problem with intake of salt or way too much water. So primary polydipsia, okay? So you're drinking too much water, or beer potomania or tea and toast diet, the cases I told you guys where you're not taking in enough sodium in your diet to begin with, which is, by the way, very rare. That's why you have very specific diets for it. And then we say no. Okay. So urine osmolality is high. Okay. High urine osmolality, low serum, low sodium. That's where we are in this algorithm. So now, is the urine sodium less than 25? So if the urine sodium is low, okay, then we know that, okay, this is probably a case of activation of RAS, because renin, angiotensin, aldosterone, if the sodium is low, that means you're reabsorbing it somewhere. So you're going to get volume depletion, congestive heart failure, cirrhosis, all those things we talked about. If urine osmolality is high, so your urine is very concentrated, okay, then you're going to start to think of a syndrome of inappropriate ADH secretion, adrenal insufficiency, and hypothyroidism, okay? So this is what you need to know in a nutshell. So this is the practice case that you guys had in the LGD. So if you're still with me, Sharkoni, please participate on the chat. And please, I emphasize this now. Adi, if you say something wrong, don't worry about it. We're all here to learn. And I just always want you guys to keep that in mind. Don't be afraid to participate because you don't want to get things wrong. Get it wrong now so that you don't get it wrong in the exam. It's actually better for you. So this is the case, all right? We have a 55-year-old male, with a known case of heart failure, diabetes, and hypertension. Okay, so those are 3 key things we need to think about. Presented to the ER with nausea and vomiting for the past week. His blood pressure is 100/60, which is low. In labs, sodium is 120, potassium is 3.1, bicarb is 18. What is the main cause of hyponatremia in this patient? So initially, before we even get to asking any questions, let's look at the demographic, okay? So he has heart failure. So because of his heart failure, he can have the hypervolemic type, right? That's one option. Because of his diabetes, he could be having polyuria polydipsia. That's another cause of hyponatremia. Nausea and vomiting, that's a third cause of his hyponatremia. So off the bat, it doesn't really give us a good idea of what is the cause because there are a lot of different factors playing in. Okay. And so what is the main cause? First and foremost, and you guys take this as a rule, especially because you're going into the hospital next year, inshallah, or next semester. I'm very happy for you. So first, history and physical, very important. You need to assess the volume status of the patient. If, for example, he has heart failure and I tell you, oh, he has lung crackles and peripheral edema, he's in a very fluid congested state, then that can give you immediately a clue, okay, that's probably the cause of his hyponatremia, right? Activation of RAS. If he's euvolemic, everything is normal, then you start to think, maybe it's syndrome of inappropriate ADH secretion, right? If he's hypovolemic, okay, maybe it's from the nausea and the vomiting, maybe he's dehydrated. So, immediately that in and of itself is going to give you an excellent clinical clue as to what is the different cause, all right? Then we're going to ask for further labs. So we know it's sodium is 120, but remember, he's diabetic. What if this is a hyperglycemic state? So we need to know the osmolality of serum and urine, because if serum osmolality is high and the sodium is low, then you know that it's a hyper osmotic hyponatremia. Okay. And urine, same thing. We need to determine the type of hyponatremia with the algorithm that we just saw. So this is what we got back. His physical exam showed no signs of dehydration, no lung crackles, edema, or JVD. So immediately we ruled out heart failure as a cause. Why? Because there's no lung crackles, no peripheral or pitting edema, no jugular venous distension. JVD, by the way, for those of you who may not remember, is when you have too much fluid overload, specifically in the heart, you start to get dilation of or distension of the veins in the neck. So that's what we call JVD, jugular venous distension. Okay. And so now let's look at the serum. Serum is 250 milliosmoles per kilogram. So this serum osmolality is low. So now we know, okay, we're dealing with a true hyponatremia, right? Because sodium is low, okay, and the osmolality is low. So now we know it's khalas. We know the case that we're dealing with. And I told you he has a high urine osmolality. So remember, on the left side of the figure that I showed you guys, those are the ADH dependent causes. So what that means is the patient has a good perfusion, okay? So in this case, we know by physical exam, there's no signs of congestive heart failure, cirrhosis, no edema, these things. So the patient is euvolemic. And euvolemic with high urine osmolality is going to tell you that this is an ADH dependent cause, most likely because you're producing way too much ADH. Why? Because this patient isn't displaying any features of heart failure or Addison's or, like adrenal crisis, those things. So it directs our clinical view to think, okay, this is SIADH. And then you start to think of what are the potential reasons that you could have SIADH. All right. So the cause in this case is too much ADH production or syndrome of inappropriate ADH. So there's a lot of different etiologies. All right. So in this case, you can look here, for example, it can be due to CNS disturbances, if there's stroke, trauma, pneumonia is a very common cause, specific medications, it can be due to lung cancer, pain or nausea in general. So because he said he's had vomiting, the nausea could be the cause of the SIADH. So in this case of hyponatremia, the way you're going to manage is his case is moderate. So mostly what you're going to look towards is some fluid restriction. So prevent him from drinking too much water to dilute the blood even more. Okay, so just to reiterate, in SIADH, you're going to have hyponatremia, okay, with low serum osmolality, so it's a hypotonic state, high urine osmolality, and also high urine sodium. They didn't give you urine sodium in this case, but again, you would keep this in mind because you already eliminated the rest of the causes. All right. And so in summary, for sodium, hyponatremia, I know is a big topic, and usually we have these in lectures in and of themselves, but I hope this kind of summarizes it for you nicely. True hyponatremia, okay, where you have low osmolality, can be hypovolemic, euvolemic, or hypervolemic, okay? In hypovolemic, if you have low urinary sodium, that means, you're hypovolemic and you're dehydrated. So here you're going to have non-renal salt loss, like vomiting, diarrhea, dehydration. If urine sodium is high, then it can be due to renal causes. So diuretics, primary adrenal insufficiency, okay? Euvolemic states are going to be urinary osmolality less than 100. So remember, if everything is low, this is low, they're euvolemic, and the urine is low as well, low osmolarity, then it's going to be, or can potentially be psychogenic polydipsia, which is basically the patient is just drinking way too much water, and this is associated with usually other disorders like OCD and beer-potomania. Okay, again, you're not taking in enough sodium, also the tea and toast diet, but they just didn't write it here. Okay, euvolemic with high urinary osmolality, which is the case we just saw, is SIADH. So you need to rule out hypothyroidism and secondary adrenal insufficiency. Okay, in hypervolemic states, the urine findings can be variable, but the key thing for you to know is that by the physical exam, you will know they're hypervolemic. They have pitting edema, crackles, maybe jugular venous distension, so congestive heart failure, cirrhosis, nephrotic syndrome. All right. And for normal or high serum osmolality, there's different causes. So pseudohyponatremia is when you have increased proteins. It's essentially a problem in the lab. The lab is detecting the proteins to tell you there's normal osmolality, but there isn't. And then you have high, which is what we talked about, DKA. So hyperglycemia, you're giving mannitol or something. So this is just everything we talked about in a nice little table for you guys. Now we're going to move on to hypernatremia. But before that, do you guys have any questions? Or inshallah, easy peasy. Are you guys there? Okay. Thank you, Shahad. Okay, Tariq, you asked, how do you tell that it is hypovolemic? So hypovolemic by physical exam. So you're going to see dehydration. So one of the things we test for example, is skin turgor, which is you basically take the skin and see how well it does that. And capillary refill, so these things by physical exam. You're going to get to know that more later. So by history and physical, you're able to determine mostly whether it's hypo or euvolemic or hypervolemic. So again, for example, the patient is on a diuretic. So you know that the diuretic can cause more urine to be, more sodium to be excreted in the urine. That's how it works, right? So in this case, you're going to, and the urine osmolality is high, they're hyponatremic. So you're going to know that, okay, this patient has hypovolemic because they're on diuretics. Let's change it, for example. Or patient appears very dehydrated, there's vomiting, there's diarrhea. Those are what are going to give us our clinical clues to direct our thinking towards hypovolemic hyponatremia. Does that answer your question? Can you please provide us with the normal values for urine osmolality and urine sodium? Okay, so urine osmolality, for a serum we know, okay, we said generally like 275 to 295 is the general range that we're looking for. For osmolality, it really differs because it can go up to like 1,200. So the general cutoff that we're looking at here is 100, okay? So it's a very complex topic. I'll try and put all the values up for you guys later, all right? But let's move on to hypernatremia. But wait, let me write it for you. Sodium normal values is 135 to 145. And the osmolality, again, is very variable, but I'll send you guys what I have in a bit. So hypernatremia, is, like I mentioned earlier, the true meaning of dehydration, okay? So it can be caused by one of the following. You're really dehydrated. You're not drinking water at all. So what's going to happen is your blood is going to be very concentrated, okay? It can also be caused, on the contrary, by excessive water loss, okay? These are just, logical. If you take too much sodium, you can have hypernatremia, okay? Or if you're retaining too much sodium, you can also have hypernatremia. And if you have transient intracellular free water intake, you can also have hypernatremia. Sure, I'll send you guys the document. Just give me a moment. Because I know it says electrolytes. I'm going to give you guys a 5-minute break once we're done with hypernatremia. So just give me a moment and then I'll send you guys everything. It's sort of very basic. I mean, hypernatremia is much easier than hypo. So if you have hypernatremia, right, too much sodium in the blood. So here it's more than 145, okay? Either you're losing too much water, so GI losses, insensible losses. So here we are thinking of diabetes insipidus. So diabetes insipidus, the reason it's called diabetes is because these patients used to urinate too much, although the underlying cause of diabetes insipidus and diabetes mellitus are different. So it's basically a case where your body is not responding to antidiuretic hormone properly. And we know antidiuretic hormone, from its name, anti, against, diuretic, diuresis means, churning. And hormone, it's a hormone. So it causes us to retain more water. You can have central causes, meaning in the hypothalamus, you're not producing enough ADH, and you can have nephrogenic, so causes in the kidneys. And there are a lot of things that can do this. Changes in the balance of calcium levels, and also hypokalemia or hyperkalemia, a lot of different things. Lithium is a drug. So we don't want you guys to know this right now. I just want you to understand that there is some overlap between hypo and hypernatremia. That's why it's very important for you to get labs, okay? Like, for example, we said you can have hyponatremia, that is hyperosmolar, because you're giving mannitol. Okay, mannitol is also a diuretic, so it can cause osmotic diuresis as well. There's a lot of overlap. So that's why it's very important for us to look at the different laboratory values in order to properly classify and treat. Because, for example, if you saw a patient, you're like, oh, he's on mannitol, just give him a bit of sodium, and he's hypernatremic. Okay, you just caused an even bigger problem. So just keep that in mind. You can also have sodium overload, so someone that is eating way too much salt. Okay, someone got IV fluids. Remember, like, let's say someone with hyponatremia came, they gave him IV fluids too rapidly, they corrected too much, now he's hypernatremic. So these things can happen. You can also have it due to transcellular movement of water, so seizures, exercise. What's more high yield for you guys to understand is how osmotic diuresis and water loss can contribute to hypernatremia, being diabetes insipidus and uncontrolled diabetes because of glycosuria or glucose in the urine that's causing you to urinate more. So these are the general clinical features that we can look at. Okay, so like everything, you can have mild, moderate, and severe. So severe hypernatremia, just like severe hyponatremia, can cause changes in the brain. So seizures, stupor, coma, altered mental status. And remember that here your cells are very small. They're like shriveled up because all the water is leaving. So you tend to get thirsty. You tend to have dry mucous membranes, dry skin, confusion, irritability, lethargy, all of these different things. But chronic hypernatremia is usually asymptomatic. So let's say you have a patient with hypernatremia and it's very high, but he has no symptoms. Then you're not going to be as inclined to treat it because, again, the patient is not symptomatic. So that's why it's important to look at the whole clinical picture. It's not always as easy as it seems in the vignette. Okay, and so the way you'd usually treat patients with hypernatremia, wait, before the break, I'm sorry, is you can do IV fluid correction, just to get it down. And you can also have, increase their fluid intake if that's the cause of their dehydration. So it's a very complex thing, but essentially you're going to treat the underlying condition. I don't want to get into too much details, which can be frustrating sometimes when you feel like you don't understand the whole picture. But this is what you guys need to know for your level right now. Okay, and we're gonna have a 5-minute break, but for now, do you guys have any questions? Let me know. I'm gonna set a timer. And I'm gonna send you guys the PowerPoint. So, all right. No, before the 10-minute break. Wait, I don't want to spoil the cat pictures. They're the best part of the lecture. Okay. All right, guys. Huh? You want to join us? Okay. Okay. Come join us. It'll make the lecture better, I'm sure. Come. Say hi to everyone. Say hi. Okay. She's on the table. Anyway, so now that Lesga is with us, yes, my cat's name is Lesga. اسم على مسمى. Okay, we're going to go and move with potassium disorders. Okay, so first of all, normal value. Remember, before we do anything, potassium is higher intracellular than it is extracellular. Remember the first year type picture that I added in the beginning? And so in the serum, its normal range is going to be between 3.5 and 5. And disorders of potassium are very dangerous. The reason is it's very important for the stability of, muscles, and specifically cardiac muscles. So essentially, if you have severe hypo or hypernatremia, you can go into cardiac arrest. Okay, so that's why when any potassium disorder is present, we tend to act very rapidly. But as you guys saw with sodium, sometimes if it's chronic, asymptomatic, we tend to ignore. But potassium is not that type of IOP, let's just say. So as we just mentioned, it's a major function, or its major functions are within cellular metabolism, and it's a major determinant of resting membrane potential across the cell membrane. And because of that, remember, it's very important for the action potential. The way sodium goes, causes the influx, and then potassium efflux. And so essentially, it's very important for normal neural, so for your nerve functions, and for your muscle function. And so I know it looks very complex, but we're going to figure out how to do this together, all right? So potassium is reabsorbed in the body from the urine. There is active reabsorption and there's passive reabsorption, right? Passive and active transport, very important. So most of it is reabsorbed passively in the proximal tubules, which you can see here, right? Potassium is going up and water follows sodium, okay? And so most of the potassium we need comes back from the proximal tubules. But then you have other things, like in the thick ascending loop of Henle, the sodium-potassium 2 chloride pump, a good portion is here, but this is active transport. It is no longer passive transport, okay? And then you have other things, so connecting the segment outer medullary kidney, you have a ROMK channel, Okay, and this causes potassium to be excreted. All right. And so these are present in the outer medullary kidney as well as the collecting ducts and principal cells. Okay. And lastly, although it is a small portion, it's very important to note that you have a, H plus, K plus ATPase in the alpha intercalated cells. And so it's the exchange of potassium and hydrogen is important because, excuse me, because as we're going to see, sorry, Liska, don't give me your butt. Oh, it's okay. Because as we're going to see, she's my child, so please excuse this. As we're going to see, what happens is in a state of acidosis, okay, you're going to have differences in the way you secrete potassium because you want to excrete more hydrogen as well. And we'll see that in a second. I don't want to spoil it just yet. All right. So again, most of the passive reabsorption occurs here. All right. You also have active reabsorption in the thick ascending loop of Henle by the sodium potassium 2 chloride channel. Okay. And you have potassium actively excreted by the ROM-K channels. Okay. And it's very essential that we just get a general picture of this. So when we talk about hyperkalemia, first of all, so hyperkalemia is when levels of potassium exceed 5.2. Remember, the normal is between 3.5 to 5. And the main clinical manifestation are going to be muscle weakness and cardiac arrhythmias. And so cardiac arrhythmias are very important because we need to fix this immediately, right? Because if the heart is compromised, then you can go into cardiac arrest and the patient will bear the shot, inshallah. No one ever has to go through that. And then the patient may die. So this is what happens in hyperkalemia. And so you can have cardiac arrhythmias, like I mentioned. It can be bradycardia, atrioventricular block, and ventricular fibrillation, which you guys learned about in CVP. You can also get nausea and vomiting, as well as diarrhea. You can get paresthesia because remember, it's very important for the conduction of nerves. So when potassium is very high, that balance is thrown off. You can also get muscle weakness and paralysis. All right. And decreased deep tendon reflexes. So think of everything as kind of being more flaccid. Okay. And so we have to rule out what we call pseudo hyperkalemia, which happens when you clench your fist during venipuncture. So when someone is trying to take your blood, and what can happen is that can break open the cells. And like we mentioned, there is more potassium inside the cells. So that can cause the laboratory values to be falsely increased. Okay, so that is generally what hyperkalemia may look like. And the underlying conditions that the patient has can tell you whether or not there's a cause of hyperkalemia. For example, if a patient is in DKA or diabetic ketoacidosis because of type 1 diabetes, for example, they have a deficiency of insulin. So when you have a deficiency of insulin, what happens is the insulin causes potassium to go into cells, and that's not happening. So there's a lot of potassium outside because there's no insulin to help it go inside. So that can cause a hyperkalemia, although the total body levels of potassium are low. Okay. And within the same realm, you know how we said there's more potassium inside the cells. So if they explode for some reason, then you can have a hyperkalemia. So if you have rhabdomyolysis or breakdown of the muscles, if you have tumor lysis syndrome when you're treating a cancer, like let's say a leukemia or a lymphoma, and you break them down in the blood and they start to explode and release all their contents. Okay, so those are just some causes. Maybe you can't release it, you can't excrete it, so you have kidney disease, okay, or due to specific drugs. So those are just, the causes. I just want to show you that with the picture on hand. Now I'm just gonna go through them again as Dr. Khalid mentioned them. So causes of hyperkalemia, dietary. And this is very important because inshallah you guys will be at least training in Saudi, if not practicing. Let's say you have a patient that has chronic kidney disease, meaning their excretion of electrolytes at a baseline is not as good. And you ask about their diet, ويقولوا لكم إنه أيوة كل يوم 10 تمرات or something, or I eat 10 dates per day. And dates are very high in potassium, so they can have hyperkalemia just because of that. So cultural considerations are also very important. Maybe you have potassium-containing medication. Like, let's say you're giving the patient a diuretic, but it's a potassium-sparing diuretic. So, of course, you can get hyperkalemia, you know what I mean? Also, things like KCl or potassium chloride. Penicillin can also cause hyperkalemia. Excess intakes of some fruits, herbal extracts, red blood cell transfusions. So those are just some causes of increased input of potassium. Okay, what about the other way around? What if we're losing potassium for some reason? So if you have very severe chronic constipation that can impede it would cause your body to reabsorb more potassium because nothing is flowing properly through your GI. And within the same realm is what I mentioned. If you have chronic kidney disease, maybe you're not excreting your potassium as well. All right. And then you have your extracellular shift. So this is very important, and I'm going to show you in a picture in the upcoming slide. But essentially, acidosis, whether metabolic or respiratory, can cause your hyperkalemia. Okay, so this is basically what happens. Remember how I told you there's an important relationship between hydrogen and potassium? In cases of acidosis, remember that the body is always trying to come up with it's like a seesaw, you know, like the acid goes up. Okay, I want to lower it back down. I want to fix this problem. That's how the body tends to work. And so what happens is when you have an acidosis, when you get more hydrogen ions inside the cells to try to compensate or to try to fix the problem, the body still needs to be in balance. Okay, one positive ion in, I'm going to take one positive ion out. And so when the hydrogen ions go inside, it's going to kick out the potassium. So that can consequently cause hyperkalemia. And in alkalosis, it's the opposite mechanism. If you have an alkalosis or your pH is too high, there's not enough hydrogen ions, the opposite happens. The hydrogen is going to leave. Your body's going to say, okay, I lost one positive ion inside. I have to replace it. So your potassium is going to start to shift into cells. And this is just a very important thing that you guys understand from now, because you're going to see how this, can play out in different cases. So, for example, when we mentioned diabetic ketoacidosis, there can be multiple mechanisms for the hyperkalemia. It can be hyperkalemia 1 because you don't have insulin, which is helping the potassium go into cells. Second reason, it's an acidosis, right? Diabetic ketoacidosis, it's in the name. And if you have an acidosis, your body's going to try and compensate to put the acid inside. And when the positive ion goes inside, you need to push another positive ion outside in order to maintain that electrical balance. Okay, and this is a very important concept. So if you guys have any questions now, please stop me and let me know. Okay, so acidosis causes hyperkalemia and alkalosis causes hypokalemia. And if you ever forget one or the other, just remember the shift in hydrogen. Acidosis, too much H+. I want to put some inside the cell. When I do that, I'm going to have to kick potassium out. Alkalosis is the opposite. I want to kick the hydrogen outside of the cell. So I want to put potassium inside. Okay, so whenever you guys get confused, don't feel like you have to memorize every single detail. So long as you understand that, you will be able to use your deductive reasoning to get to a point that you can answer the question correctly. And more importantly, that you keep this in mind when you deal with patients in the future. All right. So now let's continue on causes of hyperkalemia. So therapies that cause low insulin, same thing, same line as diabetes. So this would be octreotide, which decreases secretion of a lot of things. You're going to see that more in GI, inshallah. And then other causes of hyperkalemia like cell death or increased tissue catabolism. So remember, this is what we said before. If there's more potassium inside the cell and the cell explodes, potassium is going to go in the in the plasma and cause hyperkalemia. So this can be due to tumor lysis, trauma, rhabdomyolysis, severe hypothermia, because in severe hypothermia, you're shivering so much that it can start to break down the muscle cells, and hemolysis as well. And then you have altered sodium potassium ATPase activity. We talked about insulin. Another very, very, very important cause is reduced beta-2 adrenergic activity. So if the patient is on digoxin or the patient is specifically on beta blockers, and this is a good question for them to ask about, so keep like insulin and beta blockers in mind. If the patient is on any of these, or on beta blockers, digoxin, or is, let's say, in DKA or is type 1 diabetic, this can cause hyperkalemia. All right. And then you have other medications, succinylcholine, heparin, less specific, but this is important because it ties into the pathophysiology, because you have decreased activity of the sodium potassium ATPase, remember? So 3 sodium out, 2 potassium in. And now, what they love to ask about is the ECG changes in hyperkalemia. So both hyper and hypokalemia can affect the ECG. In hyperkalemia, what you get is first of all, depends on the level. So remember how we said greater than 5.2 is hyperkalemia. Generally, once you reach 6 to 7, what you start having is a prolonged PR interval. Okay, you have prolonging of the PR interval, and you start to have a tall peaked T wave. Okay, so this is the main characteristic thing that you're going to see in hyperkalemia. It can also be seen in some MIs, but just keep in mind tall peaked T wave. And then the phase after that is, first we had a prolonged PR interval, then we completely lost the P wave, okay? And you started to have now an ST elevation and a tall peak T wave still. So you see how the ECG is morphing based on the level of potassium because that electrolyte balance is thrown off. And then when you get even higher potassium levels, so greater than 8, you start to have a widened QRS, like a sine wave pattern, which I'll show you in a second. You can also have blocks of the heart. Remember how in the picture from Ambas, it said you can have bradycardia, you can have AV nodal block. Essentially, you're losing the ability of the myocardium to contract properly because the potassium is so high. So that electrical balance is completely thrown off, okay? So this is what you can see. So here you can see the peak T wave, then you start getting loss of the P wave with a peak T wave, and then you can have, here is the same, so loss of the P wave, and then you're gonna have wide and QRS. You see how usually, like here, it's very narrow, here it starts to widen, and you still have the peak T wave. So this is when we start to get to the more sinusoidal pattern. So you see what this looks like? Like this is essentially what the ECG is going to look like when you have very, very, very high potassium. And that's going to lead to something called ventricular fibrillation, which is the heart is trying to contract, but it can't. So this is, of course, an emergency. And that's why when you have someone with hyperkalemia, the first thing you're going to do is an ECG, because I need to know, is the heart okay? Because all the other symptoms that the patient has are non-urgent. But if the heart isn't pumping, then the patient is dead. So what we do, and you're going to learn this when you get to your ER rotation in 5th year, is one of the first things you want to do is give calcium gluconate. And the reason you give calcium gluconate is because it stabilizes the myocardium. And once you stabilize the myocardium, khalas, you're good. Okay, you can start to deal with this without as much haste. You're going to do repeat labs because you want to continue to evaluate. And remember the pathophysiology that we talked about. We said low insulin, acidosis cause hyperkalemia. So why don't you give insulin? It'll cause the potassium to shift into cells. So these are solutions. And when you give insulin, of course, insulin is going to cause glucose to also go inside the cells. So you want to give it with D50 or dextrose, okay? So, you don't want the patient to be now hypoglycemic. That's going to cause more problems. So we just need to keep these things in mind. You can give albuterol inhalers, okay? So albuterol or beta agonist is going to do the opposite. Remember, it's going to increase the activity of the sodium potassium ATPase, cause it to shift inside, okay? The opposite to the beta blockers. Same thing, sodium bicarbonate. This causes an intracellular shift of potassium, So again, it's very important for you guys to understand the pathophysiological mechanism, because through that, now you're going to understand, okay, hyperkalemia. And the same way that can cause hyperkalemia, these things can cause hypokalemia. If you give too much insulin, all of it is going to go inside, right? If the patient is on chronic albuterol use, if the patient is using albuterol chronically, like let's say they have asthma, they can have hypokalemia. I'm in a lecture. You want to say hi? I'm in a lecture.
Oh, sorry.
Okay, they've been nagging all day. That's my mom. Anyway, so sodium bicarbonate or alkalosis can cause intracellular shift of potassium. So these can cause hypokalemia. Just keep that in mind, because it's a spectrum. It's not like you're learning something different. It's just this can do that, and then the opposite. So the treatment, you can give potassium binders, you can give furosemide, which is going to cause excretion of potassium and sodium. And in worst case scenarios, in very, very severe cases, you can do dialysis. if it's refractory to every treatment that you're giving, just remove the potassium from the blood completely. So this is a nice mnemonic I found. So this is what you need to know for the etiology of hyperkalemia. It's a bad loss. So beta blockers, acidosis, digoxin, cell lysis, hyperosmolarity, high blood sugar, and succinylcholine as well as another cause. Okay. And this is also a nice summary table to show you what you need to know. You're going to have peak T waves, prolonged QRS, widened QRS, loss of the P waves. So remember, this keeps going as the level of potassium progresses. And so you can get conduction blocks, ectopy, or sine wave pattern. So what you do first is you give calcium gluconate, stabilize the heart, and then you can do rapidly acting treatments like insulin with dextrose. You can give beta-2 agonists like albuterol, and you can give sodium bicarb. Okay, so last resort is removing potassium from the body. So diuretics, cation exchange resins, and hemodialysis. That's what we said. I just found it in a beautiful table from UWorld. Now we move on to the opposite, hypokalemia. And in hypokalemia, because the potassium is so low, remember how the potassium is very important with like lowering the action potential back down. So when potassium is low, think of the muscle as being very excitable. So you get muscle weakness and fatigue, and it's usually characterized by tetany. That's why if you see, for example, which you guys are going to take an endorecro, in basically you can have hypokalemia secondary to other things, all right? And so similarly, you can have what we call tetany, so muscle twitching. EKG changes, so you're going to have something called a U wave, T wave flattening, ST segment depression, asystole. So think of this as the opposite of hyperkalemia. So U wave usually comes after the T wave, but before the P wave, it's like a random extra bump. And instead of your T wave being peaked, as it was in hyperkalemia, it's going to be flattened much more than normal. And instead of ST elevation, you're going to have ST depression. So if you memorize one, you kind of know the rest just by, reversing it all. And you can have asystole as well. You can have nephrogenic diabetes insipidus. Remember, when basically your kidneys no longer respond properly to the ADH because of the electrolyte imbalances. And you can have hypokalemic nephropathy. But one very important and very high yield thing for you guys to know is 40% of patients with hypokalemia have hypomagnesemia. So there's a transporter in the distal tubules, like, in the collecting ducts and whatnot. And those transporters require magnesium in order to function. So they're going to cause excretion of potassium so long as magnesium isn't there. So if you have a patient with hypokalemia, let's say you give them potassium, if you don't correct the magnesium first, no matter what you do, they're still going to have hypokalemia because they're losing more potassium through that transporter. You didn't do anything. You know what I mean? So what's very essential in this patient group is that you treat the hypomagnesemia first, and then you treat the hypokalemia. That's something that's very high yield. I don't think they will ask you about this on your level. I just want you to keep in mind for your future, because it's a very key thing regardless of what specialty you go into, because electrolyte imbalances are very important in general, whether you go into ER, family medicine, or this or that. Just always keep that in mind. Okay, so this is what you can see in hypokalemia. You can get constipation, you can get cardiac arrhythmia. So here, instead of slowing down the heart rate, you're speeding it up. You can get palpitations, they can have syncope because the heart is not pumping properly, and hypotension. You can get polyuria, remember the nephrogenic diabetes insipidus. You can get neuromuscular problems like cramps and spasms, weakness, deep tendon reflexes can be decreased. Okay, and other features, you can also have hyperglycemia, and again, symptoms will always depend on the underlying cause. Okay, the reason you have hypomagnesemia, I'm going to show you in a picture, so you can see it better. Just give me 1 second. Okay. Just give me 1 second. I want to find a good picture for you guys. Mm, let me Okay, I can't find a picture, but basically there's a transporter, okay, and the distal tubule, or is it the distal tubule? Let's just say there's a transporter, okay, in the later part of the kidneys. And what it does is it's essentially going to cause your potassium to be excreted, okay? Now, it acts as a channel, okay? So your potassium is leaving into the urine because of this channel. The way you block this channel, or the way it's regulated, is by magnesium. Like, magnesium is a very important cofactor for this to work. So when you don't have magnesium, what's going to happen is it's like a channel that's open. And what's going to happen is, if let's say I have hypokalemia, okay, and I don't correct the magnesium, what's going to happen is I'm going to give potassium and it's going to go through this channel again. I'm going to give more potassium, it's going to go through this channel again. So you're treating it and it's kind of useless. So what you would do instead is you would give magnesium first, so correct the underlying hypomagnesemia, and then you can give potassium. Then it'll stay, because this transporter then starts to become regulated. It doesn't let go of all the potassium. Okay, does that make sense? I'll find the exact one that it is. That's just the essential concept, that if you don't correct your magnesium and you treat with potassium, it's useless. Okay. So causes of hypokalemia: decreased input, so low potassium in your diet. So, and this usually happens in very severe malnutrition. Okay, and you can see it in specific things with clay ingestion, which is very weird and specific. So just keep that in mind. And then same thing for everything else: increased output. Maybe the patient is on dialysis, they're losing potassium. There's urinary losses as well as burns, GI losses. All of these different things can cause you to lose more potassium, and that can cause the hypokalemia. Intracellular shift, remember, this is very important. It's the opposite to the other one, and it's a key thing that they can ask you guys on. So alkalosis, the opposite of acidosis. Remember, alkalosis, I want to get the hydrogen ions outside because I want to correct this. So what's going to happen? I lost a positive ion inside myself, so I'm going to replace it with potassium. Okay, so you can get hypokalemia due to alkalosis. Let's say you gave too much insulin, you get increased sodium potassium ATPase activity. Okay, and same thing, increased beta-2 adrenergic activity. So you're giving albuterol, let's say the patient is on inhalers, dopamine, dobutamine, amphetamines, okay, or, drugs and whatnot. So that's, methamphetamine, so meth. People with like drug abuse can have this presentation as well. So hypokalemia due to amphetamine use, among a plethora of other things. But I just really want to make sure you guys understand the intracellular shift, because it's very important. So hypokalemia treatment, replace with potassium supplement, so KCl, but always correct magnesium first, because like I tried to explain, if you don't correct magnesium, then no matter how much you correct the potassium, it's going to be useless. And this is the case in 40% of patients. So make sure you always check magnesium in the electrolyte panel in a patient with hypokalemia. Okay. Is everything clear for everyone? Do you have any questions about potassium? Any questions about sodium? Because we're going to go into electrolytes, sorry. We're going to go into acid base, and that way, like, a huge chunk of the lecture is already done. So just let me know. All good? If you guys want a longer and or shorter break, just let me know. Inshallah, we will be done before 9. I don't want to overestimate. Okay, amazing. So what I'm going to do is I'm just going to share my screen because I want to make sure that you guys can follow along with me. All right, got it. So I'm going to share my screen on my iPad. And all right, start broadcast. Because I just want to make sure you guys can see me. Okay, wonderful. Okay, I hope that's clear for everyone. I'm gonna hide myself because that's kind of weird. Okay, Bismillah ar-Rahman ar-Rahim. Now, you guys, we're gonna talk about the approach to any acid-base disorder. So, inshallah, after this, it's gonna give you a very simplified algorithm that you can use to apply to any acid-base problem you get your way, whether now or in the future, inshallah. So, as with everything in medicine, number one is you're looking at a patient, you're looking at a human being. So you need to talk to that person, you need to understand what's going on, what is the problem exactly. So patients presenting symptoms. For example, patient is presenting with vomiting. Okay, you're losing hydrochloric acid from the stomach. So you're expecting from the vomiting alone that maybe this patient has a metabolic alkalosis. Hypokalemic, maybe hypochloremic metabolic alkalosis, right? If the patient has diarrhea, well, diarrhea is more alkaline. So you'd suspect, I'm losing a lot of alkaline fluid. Maybe I have a metabolic acidosis. If you see a patient that's hyperventilating, okay, so they're excreting a lot more CO2 than normal just because they're breathing very heavily, then you can think, maybe I have a respiratory alkalosis. See what I mean? If the patient is hypoventilating, let's say they're connected to a ventilator in the ICU, they're not breathing properly, maybe to link back to what we said, maybe they have respiratory depression because they have hyponatremia, for example. And then you can think, maybe this patient has a respiratory acidosis. So it's very important that at the get-go, you link these things. One, for you guys to better answer the questions, of course, but more importantly, for you guys to be able to catch these things in a patient, because you don't want to see a patient and then have, the consultant or whoever it may be when you're in residency ask you to start thinking about these things. These should be things that you consider at default. Okay, so just keep that in mind. When we're learning these things, we're learning these things so that we can help people and to the best of our abilities. So that's step number one. Okay, you talked about the patient's presenting symptoms. Well, now we need to look at the ABGs, or mostly, by the way. So, in clinical practice, they use VBGs more so than ABGs. So just keep that in mind because it's harder to get an ABG unless you have a specific indication. So just keep that in the back of your mind, all right? So first, we're going to look at the pH because we want to know, is this patient in acidosis, meaning pH less than 7.35, or is this person in alkalosis, meaning pH greater than 7.45? Okay, so I'll write it down so you guys have that in mind. So normal pH range, okay, is 7.35 to 7.45. Okay, so just keep that in mind. All right, so anything less than this is going to be an acid or acidosis. Anything greater than this is or I'll say acidosis. Anything greater than this is going to be an alkalosis. Okay, so depending on this, we're going to see, is this patient in acidosis, is this an alkalosis, or is it normal? Then we're going to look at the PCO2 and the bicarb. So essentially what we're going to do is we're going to match the different levels to see, is this an acidosis or is this an alkalosis, and what kind? Is it because I'm breathing, maybe breathing problems, or is it a metabolic problem, or is it both, which we'll see in a second. So first things first, if pH is low, we know it's an acidosis. Okay, if pH is low, but bicarb is very high, then what's happening? So bicarb is very high, which is here. So pH is low. My bad, sorry. I meant pH is low and PCO2 is high. My apologies. So if you have a lot of carbon dioxide in the blood, that's going to create a lot of carbonic acid. So if we look at the equation on the right-hand side here, all of this is based on the following principle, where if you have very high CO2, what's going to happen? Your body is going to say, okay, I want to figure out a way to fix this. I'm going to shift from here, okay, and it's going to give you more H+. Okay, and so you're going to shift back and forth. So any increase in CO2 is going to shift the equation to the right. That's going to lead to a respiratory acidosis. Altayeb, let's say we're looking at it clinically. Why would a respiratory acidosis happen? Let's say you're not breathing properly. Okay, someone is hypoventilating. They're not able to clear the CO2 properly from their lungs. If you're not able to clear CO2, you're going to have a lot of CO2 buildup. If you have a lot of CO2 buildup, you're going to have this equation shift to the right. Okay, so here we'd expect a respiratory acidosis, and maybe patient is in the ICU, maybe they're hypoventilating, maybe they have cerebral herniation. That's like a very dramatic example, but just so you guys can link the two things that we talked about. Okay, what if we look at the other end? What if pH is high? I'm going to erase this. Okay, what if pH is high? So it's an alkalosis, okay, but CO2 is low. So this is now a respiratory alkalosis. So you see how the arrows are matching, okay? So if in respiratory cases, it's always the opposite. Another mnemonic for it is RO, okay? So the arrows are going to go in opposite directions. So in respiratory, they're opposite. So respiratory alkalosis and acidosis. I used one more S than necessary. Okay. And metabolic is equal or same. So here we're just talking about the direction of the arrow. So you see how here it's opposite. So similarly, respiratory alkalosis. What's going to happen? If CO2 goes down, the body always wants this equation to be in equilibrium. So it's going to shift from here to the left. And when it shifts this way, that's going to lead to a decrease in H+, meaning you're going to have alkalosis. And what I'm trying to emphasize with you guys here is that if you know this equation, you can essentially understand what's going on at a base level. That's why in respiratory acidosis, your PCO2 is high because you need more CO2. And that's going to shift to the right. Because in this case, let's say, for example, like I mentioned, you're hypoventilating. In respiratory alkalosis, it's the opposite. You're hyperventilating. You're breathing out way too much carbon dioxide. So there's less acid, right? Because it's trying to shift this way in order to compensate. Okay, so I hope this makes sense to you guys. All right, now within the same realm, let's look at the metabolic aspect. Okay, so for metabolic, I'm going to use blue so that you guys know the difference. Okay. So in metabolic, let's say we started off and it's an acidosis, meaning the pH is low. If the pH is low, then the bicarb is also going to be low in cases of a metabolic acidosis. Okay, remember, respiratory, they're the opposite. Okay, in metabolic, they're equal or they're the same. They're in the same direction. So what's going to happen? Let's say bicarb here is, bicarb is low. What's going to happen to this equation? It's going to shift this way in order to compensate for the bicarb, right? That's low. And when it shifts this way, you're going to have more H+ increasing, okay? And higher H+ means acidosis, all right? So just don't let that confuse you because the H+ is increasing. Just remember, they're the same direction, lower pH and lower bicarb. That means it's a metabolic acidosis. So this can happen due to a lot of different causes that we're going to look at later. And they're divided into anion gap and non-ion gap. Don't worry about that now. We're going to get there when we get there. I just want to take it step by step because genuinely, if you guys understand this at a baseline level, the rest is going to become so much easier. Okay. Now, if you have increased pH, remember, it's going to be in the same direction. Increased bicarb. Now you know it's metabolic. Why? Because they're in the same direction. You know it's an alkalosis. Why? Because pH is higher. So what happened here? Your bicarb was high for one reason or another. So what happened? Your H+, this whole equation shifted to this side. And when it shifts, your H+ becomes lower in order to compensate. And so when it becomes lower, you're basically going to lose acid. So it becomes an alkalosis. All right. And I want you guys to remember as well as because this equation is shifting from one side to the other, what happens is we have compensation. And compensation makes sense, right? Because you're shifting. So what's going to happen? Your CO2 is going to increase. let's say you're shifting this way, your CO2 is going to decrease. So we'll see in a moment, we have something called Winter's formula that allows us to calculate whether this compensation is adequate or inadequate. But again, just to recap for you guys, okay, in respiratory, they're in the opposite direction. In metabolic, they're equal. So first thing we're going to do, our first step is always to look at the pH, and then we're going to look at the ABGs, PCO2 and bicarb. So we know which one is causing the imbalance. Is it respiratory or is it metabolic? All right. So if pH and PCO2 are in the same direction, if pH and PCO2 are opposite, that's respiratory. Okay. If they're equal, then we know it's metabolic. All right. I hope that is clear for everyone. Do you guys have any questions moving forward? Or is it all good? Let me open the chat. Makes sense? Perfect. Okay, easy. That's the easy part. Okay, we did have the acid-base lecture. أبشركم. Now, remember what I said about compensation, right? Because this is an equation that's shifting left and right and left and right. So we now need to know, is the compensation appropriate? Is this actually effective? Is the body doing its job? Why? Because if the compensation is not what you expect it to be, then it can be what we call a mixed acid-base disorder. Meaning, it's not only an acidosis. There's, let's say, a respiratory acidosis with an underlying metabolic problem, okay? So how do we determine that? How do we understand what's going on at that level? First, let's start with respiratory, okay? What I want you guys to know is there's a compensation that happens acutely and that happens chronically, okay? So for the acute compensation, for every 1 millimole change in bicarb, okay, you're going to have 10 millimole change in PCO2, okay? So this occurs within hours. And within 2 to 3 days, you have 4 changing to 10. So the reason we care about this is because it's going to determine for us, is this compensation appropriate? So let's say you have a metabolic acidosis, okay? Or let's say, sorry, you have a respiratory acidosis, and you want to know, is the compensation appropriate? So our normal values, because it's very crucial that you guys have these in mind, I'm just going to write it down here. You know what, there's no space to write down. I'm going to write it down for you in the chat, okay? So our normal values for calculations, we said sodium, we know the normal is 135 to 145. Potassium, bicarb is usually 24 is the average of normal. But what I want you guys to know for PCO2 is it follows, you know how pH is 3.75 to 7.45. So these values, 35 and 45, are also the values of the PCO2. So if it's less than 35, it's low. If it's more than 45, it's high. That's just an easier way for you guys to remember that. I'm just going to say PCO2, okay, is like pH. Okay, so let's say this patient had acute hyperventilation, for example. Hyperventilation, we know they're breathing out way too quickly, so their CO2 is low. So let's say you have a case where the CO2 is, let's say 25. Okay, and from that, the bicarb is going to increase supposedly by 1 millimole, okay, for every 10 millimeters of mercury change in CO2. Okay, and the reason you have chronic compensation higher is because here the kidneys start to play a role. They start to create and reabsorb more bicarb in order to compensate for the acidosis. So let's say this patient has chronic hyperventilation for one reason or another, or hypoventilation, same thing. Okay, this is going to become clear to you guys when we do practice questions. I just wanted to emphasize it here. And I sent you guys all of the document details as well. So when we do practice questions, you can keep this alongside you in order to better understand everything that's going on. Okay, Now, for the metabolic problems, we're going to calculate this using Winter's formula. Again, compensation is appropriate because we need to know, is there a secondary underlying disorder? So Winter's formula says PCO2 should equal 1.5 times the bicarb plus 8 plus minus 2. So what we're going to do here is we have a metabolic acidosis, okay, or alkalosis. We're going to see, let's say our bicarb is whatever number, okay? Let's say our bicarb is 16, okay? So 1.5 into 16 plus 8, and then plus minus 2, okay? So whatever that number may be, the plus minus 2 is essential for us to know, is this compensation appropriate times? There are people racing outside my house, apparently. Plus 8. Okay, so that's giving you 32 plus minus 2. So if we look at our labs again, and they tell us that the PCO2 is either, let's say from anywhere from 30 to 34, that is normal or adequate compensation. So when you have normal compensation, that means there is no mixed acid-base disorder. It's only one, okay? And I know this might be a bit daunting and confusing to know, but I promise you, again, with practice questions, it's going to become easier. Tamam? So we calculate using Winter's formula. That's if we know it's metabolic, all right? So anything less than or more than 2 of the range is considered inappropriate, all right? So for respiratory compensation. Tamam? So if there's a mixed acid-base disorder, what's very important for us to then determine if it's metabolic is what we call the anion gap. First, I want you guys to know what is an anion gap, because it's a very big term that comes up when we learn about acid-base. We know, first of all, metabolic acidosis means low bicarb. So when there's low bicarb, what the body normally does is it's going to increase another ion, right? Because remember the same concept with potassium and hydrogen. If you decrease bicarb, your body's going to want to increase another anion in order to compensate. You don't want it to be suddenly you lose a lot of negative charge. It's way too positive. It wants to increase by something else. Okay, so when there's loss of an ion, which is what I wrote here, when there's loss of an ion, another one increases to compensate for the loss of charge. Now, if chloride is the ion that's increasing, if it's chloride, then you're going to have a normal anion gap. If chloride is normal or decreased, that means something else is compensating. There's another cause of that anion gap. There's another unmeasured anion that's increasing in the blood. And so this is when we have what we call an anion gap metabolic acidosis. And I want you guys to know that when chloride increases, that means your body is compensating. When chloride is not increasing, that means there's something else. Okay, and why is this important? It's going to separate our metabolic acidoses into 2 types, either anion gap or non-anion gap, which you guys can see here. Okay, so this is a table from, or like a graph from first aid, which I find very helpful. So we're going to check the anion gap. I'll show you how to do that in a second. But the key thing here is if it's high anion gap, then you're going to have specific causes. Another unmeasured anion that's increasing to compensate. Okay, for example, methanol, uremia, diabetic ketoacidosis, maybe patient had TB and they're treated with isoniazid. So mud piles is a nice mnemonic for you to remember them all. If there's a normal anion gap, the mnemonic is, excuse my French, hard ass. So you get hyperkalemia, Addison's disease, renal tubular acidosis, acetazolamide, etc. So the reason we're calculating the anion gap is to know, does this patient fall into this category, or does he or she fall into the other category? Okay, so now let's resume. I'm going to keep this here in the side so you can see. So for metabolic acidosis only, we're going to calculate the anion gap. And the way you calculate it is sodium minus chloride plus bicarb. Okay, so the normal is going to be 12, plus minus 4. So the same way we had plus minus 2 in Winter's formula, okay, we're going to have plus minus 4 in metabolic acidoses here in the anion gap. So what that means is we're going to calculate the anion gap. And then, so you're going to calculate the change in anion gap. If we know the normal is 12, then we're going to say, okay, this minus 12, okay, and what this means, I know it looks very complex right now, but if we're calculating the change in anion gap, okay, and we're calculating the normal change in bicarb, that allows us to see this type of ratio. So is the change in the anion gap and the change in bicarb, is the ratio normal? If it's 1 to 2, then yes, it is, okay? If it's less than 1, then there's a secondary non-anion gap metabolic acidosis. Okay, I know, bear with me, we're going to figure this out with questions. If that ratio is greater than 2, then there's a secondary metabolic alkalosis or a respiratory acidosis. So respiratory acidosis, meaning that there's going to be high CO2. Okay, metabolic alkalosis, meaning there's going to be higher bicarb. Okay, and so again, for acidotic problems, this determines if there is a single or a mixed acid-base disorder. Okay, and what I want you guys to remember as well, again, I know this looks daunting, but you guys are going to come to get better at this with practice. If I have abnormal bicarb or I have abnormal pH, okay, if I have abnormal, let's say bicarb is low, okay, bicarb is low, okay, and let's say, for example, CO2 is slightly increased. Sorry. But pH is normal. Okay, then that means it's a mixed acid-base disorder. Okay, because you can't have both of these at the same time. If the pH is normal, that means it's kind of coming into the middle range here. I'm going to re-explain everything again. Don't worry, guys. We can do it on this graph to make it cohesively easier for everyone. So the first thing we're going to do is we're going to check the arterial pH, right? To determine, we said, what's the first step? First, you're going to look at the patient. Okay, and then you're going to look at the pH. If it's acidosis, that means it's less than 3.5. 7.35, not 3.5, 7.35. If it's alkalosis, that means it's greater than 7.45. So let's look at the acidosis first. If your PCO2 is high, meaning it's greater than 44, so 45 or above, then you know it's a respiratory acidosis. Why? Because they're going in the opposite direction. Remember the mnemonic Rome? So respiratory opposite, metabolic equal. So here pH is low, right? So these are opposites. So you know there's a primary respiratory acidosis. This is your primary disorder, okay? And so here we have hypoventilation. Maybe you have obstruction of the airways, you have lung problems, maybe the patient is hypoventilating, there's weakness of the respiratory muscles, all these other causes, okay? Let's say there's an acidosis, but your bicarb is low. Your bicarb is less than 20. So now we know, because these are in the same direction, that it's metabolic, okay? That's the first thing we know, that it's metabolic. And we know that it's acidosis because pH is low, less than 7.35. Now what we're going to do is we're going to check the anion gap, okay, because it's a metabolic acidosis. What we're going to do now is, remember, it's sodium minus chloride plus bicarb. Why is this the way we're calculating the anion gap? Because remember, if chloride increases, that means there's a normal anion gap. If chloride is the same or it's low, that means there's another ion that's creating that gap for you. So now if your anion gap is more than 12, as shown here, then you're going to use the mnemonic mud piles. And depending on the type of patient, you're going to see, like, for example, they have diabetic ketoacidosis, they're on, they took methanol, uremia, they're on iron, all these different causes that can help you identify why this patient has metabolic acidosis with an anion gap. If there is no anion gap, which would be here, then you're going to think of other causes. Hyperkalemia. Maybe there's too much chloride. Maybe they have Addison's disease. It can be due to diarrhea, spironolactone, etc. Okay, so just keep in mind the reason we're calculating the anion gap is to determine these things. Usually they're not going to ask you to calculate for a secondary disorder. I just wanted to include it so you guys keep that in mind. All right, now let's go on the other side of the spectrum. All right, so you have your pH is higher. Now, if your pH is high and your PCO2, is low, that means they're opposites, respiratory opposites. So this is a primary respiratory alkalosis. Okay, so maybe this patient is hyperventilating. Maybe they're having a panic attack. Maybe they're hypoxemic, so at high altitudes because the oxygen level is lower. Maybe there's a pulmonary embolism. There's a variety of different causes. And so that's for your primary respiratory disorders. And so here, your PCO2 would be less than 36, so 35 and below, right? However, if your bicarb is high, if it's greater than 28, all right, then we're going to have a metabolic alkalosis, okay? So remember, metabolic because they're in the same direction, alkalosis because pH is high, okay? So here you're going to have bicarb excess or loss of H+. So loss of H+ can be due to vomiting, okay? And you can have also due to hyperaldosteronism, excessive bicarb, due to antacids. So there's a variety of different causes here. But the key thing for you guys to understand more so is going to be identifying the type of disorder that this patient has, okay? Oh, sorry. So what I'm going to do now is I'm going to go to another page, which is my apologies. Okay, so we're going to go through these acid-base practice questions together, all right? Yalla, bismillah. I'm going to open, where is it? Sorry, the chat box. Okay, all right. So what I'm firstly going to do is let's write out the normal values here on the side, okay? So we have the things that we usually need to calculate with. Remember, sodium, potassium, bicarb, okay, as well as our PCO2. And we know, of course, our pH. Normal pH is going to be 3.75 to, I keep saying 3.75, you guys know what I mean, 7.35 to 7.45. We know the normal sodium is 1.30, or there's no point, 145 and 135. We know normal potassium is 3.5 to 5. Okay. Normal bicarb, if I'm not mistaken, is going to be from 20 to 28, although it can vary, but this is the usual range. And normal PCO2 is going to be anything between 35 and 45. So, so technically 34 to 44. But so anything here or anything here and below is going to be high or low. Okay. Now that we know our normal values, let's go to the practice question. And again, I suggest at least for the initial few questions, you guys keep the notes open on the side. All right. So, yeah, bismillah. Just gonna close this here. All right. So let's take this question. 44-year-old male was admitted with 2-day history of severe diarrhea and was moderately dehydrated on exam. Blood chemistry showed sodium is 134, which is slightly low. Okay, potassium is 2.9, which is low. So he's hyponatremic, hypokalemic. Okay. Chloride is 108, which is within the normal range. I'll double check that for you guys. Bicarb is low, so that's very important. Bicarb is low. Okay. And BUN is 31 and creatinine is 1.5. So for the ABGs, we see that pH is 7.31. Is that acidotic? Is that alkalotic, you guys, or is it normal? You guys tell me. Okay, perfect. Yes, Sumaya and Terhad, it's an acid. Mumtaz. Okay, so we know pH is low, that means it's an acid. Okay. PCO2 is what? Is it low? Is it high? It's low. Great. Slightly decreased. Hello? Now, HCO3 is low as well. All right, we said that from here. Okay, and oxygen, ignore oxygen for now. So of these three, which ones make sense? Which ones are in the same direction? Like, we know it's an acidosis, but is it respiratory or is it metabolic? Okay, great. Metabolic acidosis, amazing, because they're in the same direction, right? Because this is down and this is also down. So we know from the mnemonic Rome, respiratory is opposite, metabolic is equal. So we're currently in this realm. Perfect. So what is the acid-base disorder? Kida, you got the primary question. But keep in mind, this patient has a primary metabolic acidosis. Now what we need to know is there a secondary disorder or not? How do we figure that out? Is the compensation appropriate? Remember from our equation that I keep mentioning again and again, our normal equation is CO2, right, plus water is going to give us our bicarb, HCO3 minus, plus H plus. So what we're saying here is that bicarb was low, right? So your equation shifted, so bicarb was low, so your equation shifted this way. So normally, CO2 is going to slightly decrease to compensate. How do we calculate that? By using Winter's formula. Winter's formula, I'm just going to write Winter, tells you PCO2 compensation should equal 1.5 times your bicarb, plus 8 plus minus 2. Okay, but what's our bicarb? Our bicarb is 16, right? Times 16 plus 8 plus minus 2. All right? Don't be ashamed to use calculators, guys. This is why we're in medicine. Okay, times 16 plus 8. Okay. So 1.5 times 16 plus 8 is going to be 32. All right? So this is 32 plus minus 2. So what that's telling us is if the compensation is within this range, that means it's appropriate. That means there's no secondary acid-base disorder. Okay, so this makes sense. Is 32 within the range of normal compensation? Yes. Amazing. So we know that this is only a primary metabolic acidosis, right? There's no secondary disorder. So now, if you guys are looking at like the notes I made, we did step 1. Okay, we did step 2, which is checking the pH. We did step 3, which is PCO2 and bicarb. We checked if the compensation is appropriate. Now, what we need to do, because this is a metabolic acidosis, and remember, this is the exception for this only, okay? what we're going to do is we're going to see, is this an anion gap metabolic acidosis? Okay. Or is this a non-ion gap metabolic acidosis? Because it's going to be different depending on the different causes. صح? So, how do we calculate the anion gap? Remember, the anion gap equals sodium minus bicarb, right? Plus our chloride. So what's our sodium value? Here, 134. Okay, minus bicarb is 16. Chloride is 108. Okay, 134 minus 16 plus 108. It's going to be 2. It's going to be 124. See, sometimes we can do math. So this is 10. Remember our normal anion gap should be around 12. Okay. Plus minus 4. Is 10 within 12 plus minus 4? Okay, perfect. So is it an anion gap or is it a non-anion gap metabolic acidosis? It's plus minus 2? Okay, good to know. It's written as plus minus 4. But I will check on that. Regardless, it's within the normal range. So that tells us it's a non-anion gap metabolic acidosis. And what's our mnemonic for knowing those? Is, again, excuse my French, hard ass. So then you're going to look at the different causes. Is it, for example, hyperkalemia? Is it Addison's disease? There's, I'm not going to write the whole list. Is it a renal tubular acidosis? Is it because of diarrhea? So knowing this whole list, what do you guys think the cause is? There's acetazolamide. It's diarrhea. Exactly. Easy enough, sir. So this patient that we just looked at was moderately dehydrated on exam, had severe diarrhea. His severe diarrhea caused his primary metabolic acidosis. Okay. So I hope, that made it much clearer for everyone. Okay. So the respiratory, just so you guys understand the labs, even though, because what we first did is we put arrows next to everything. Okay. Right. Okay. We put the arrows next to everything. صحيح? So just because the PCO2 was a bit low doesn't necessarily mean that this was a respiratory alkalosis, right? Because you have to look at the direction, or respiratory acidosis, my bad. So long as this and this match in the same direction, then we know it's going to be a primary metabolic acidosis, okay? And then we know in a primary metabolic acidosis, the compensation should be that the CO2 decreases because of the shift. How do we see if the CO2 decrease is appropriate? By Winter's formula, okay? And Winter's formula, after we calculated it, we found that it wasn't within the normal range. So that's good. That means there's no secondary disorder, okay? And then for the anion gap, we calculated it and found that it was also within the normal range. So overall, we're good. Okay, so this is a normal anion gap metabolic acidosis with appropriate compensation. Okay, does that make sense to everyone? Yes, easy enough? Okay. Amazing. See, acid base is not as bad. It just needs a little bit of practice. And so in this case, how would you treat this patient? When you treat this patient, what you would essentially do is, because they're very acidotic, so you can give sodium bicarb. but not overcorrecting, because that can cause, remember, other electrolyte abnormalities. And a key thing that I want you guys to tie in with the previous lecture is, okay, this patient has hypokalemia. Okay, so hypokalemia. If I give them sodium bicarbonate, or will that make the hypokalemia better or worse? And why? Okay, you can think about it. Just remember the general concept that we talked about, because I want you guys to tie these things in. I don't want you guys to just answer sodium bicarb because acids or sodium bicarb. But what if it makes something else worse? How do you think about it? So what I want you to remember is he has acidosis. He has acidosis. So you're trying to put, basically what that does is that puts H plus into the cell. Okay, you're gonna put K plus outside of the cell as a compensation. So, however, if I'm giving them sodium bicarb, it's gonna put us in a state that's more alkalotic. So, his potassium, is already low. It's 2.9 potassium, which is very low. So if I give him sodium bicarb, that's gonna cause the potassium to shift into cells even more, which can further worsen his hypokalemia. Okay, so just to reiterate that, this patient's potassium is already low, it's 2.9. He has a metabolic acidosis. Acidosis as a state of the body is going to push the H plus inside, and to compensate, your potassium is going to go outside. If you treat with sodium bicarbonate, remember, alkalotic states do the opposite. They push potassium into the cell, so they can potentially worsen his hypokalemia. Okay, so they can cause his potassium to shift more. And because it's so low, this is considered very dangerous. So although, yes, you would give sodium bicarb, but more likely you would rehydrate the patient and treat the underlying condition. Okay, do you guys understand that? I know it kind of sounds a bit complex right now, but I want you to keep this in mind, because medicine is not one fact at a time. Everything is very interlaced together. And it's very important to consider these things, because what if one day you're a resident and you're like, okay, patient is metabolic acidosis, give him sodium bicarb, and you didn't pay attention to his potassium. He could have died because of that. You know, not to scare you, but for now. So you get that concept in mind. Okay. Makes sense. You can say no, مرة عادي. Okay. How do we know if the patient has a secondary condition? In order to know if the patient has a secondary condition, if it's a metabolic problem, we use Winter's formula first, in order to see if there's adequate respiratory compensation or not. If there's inadequate respiratory compensation, then we can say, okay, this patient has a respiratory acidosis, or this patient has a respiratory alkalosis, and why? I mean, there's an underlying condition. Okay. I will take another case with you guys now, okay, in order to hone this in a little bit more, make it a bit easier. Okay. And this is the type of case that you can definitely see in your exam first, and of course, like in the hospital and whatnot. I just added it to the thing, so it just should take a second to load. So it comes to the file. So again, for the cases you guys had in the LGD, in the cases you guys had in LGD, like we did metabolic acidosis case, which is the normal thing you guys wanted to know. You guys also had a respiratory acidosis. خلاص, let's do a respiratory acidosis case by the time my thing loads. Like, the case you guys had in the LGD was as follows. All right, your ABG shows, I'll do this so you guys can see the whole page. Your ABG shows Okay, your pH is equal to 7.32. All right, your PCO2 is equal to 48. Okay, your bicarb is equal to 27. Okay, tamam. So this was the first thing that we went with. Wait, give me. Okay, so sorry for that. Okay, so first of all, is the pH high or low? pH is low. ممتاز. Okay, is the PCO2 high or low? All right, great. PCO2 is high. Tamam. Is the bicarb high or low? It's, a bit high. The upper range was 20. Let me just double check the exact range for you guys. Normal range of bicarb, 22 to 29. Okay, because yeah, it kind of depends. It's like on the higher range of normal, let's say. Okay. يعني هحطها on the higher range because it really depends on what you're talking about, okay? So, first and foremost, what do we notice? We know that the pH and the PCO2 are opposite. And we know respiratory, opposite, metabolic, equal. صح? So, is it a respiratory acidosis or a metabolic acidosis? Okay, perfect. So, كده we know respiratory acidosis. Okay. And depending on the case, the doctor can tell you that there's a chronic compensation or there's an acute compensation. Like what, again, the reason I was a bit hesitant to use all the cases in the LGD is that he doesn't give you any details about the patient. He's just like, okay, these are the labs. Okay. But regardless, we know that this is a primary respiratory acidosis. Hello. Now we want to know, is this compensation appropriate? Remember how I told you about the change in PCO2 by 10? Okay. Essentially, at least for what I found, is in the bicarb. Tamam. So let's say you have. I'm still in the lecture. I'm still giving the lecture. Okay, you can enjoy the lecture. It's gonna go on YouTube. I hope you know that. Sorry, guys. Okay, so usually acute respiratory acidosis is going to have a milder compensation. قولي الله يوفقكم. الله يوفقكم. شكرا. Okay. Okay. So remember what I told you guys. For every 10 millimeters in mercury change in PCO2, okay, you should have 1 millimole of bicarb compensate. What does this mean? Okay, and for, again, every 10 millimeters of mercury of PCO2, this is an acute versus chronic. هذه acute, تمام, وهذه chronic. Okay, you should have a 4 increase. 4 millimole of bicarb increase. But how do I know if the compensation is increase or decrease? Again, let's go back to the basics. CO2 plus water is going to give us bicarb plus H plus. Because it's a respiratory problem, this is very high, right? Our CO2 is high, so it's shifting this way. in order to, that's why you have an acidosis. In order to compensate, the bicarb is going to try to shift, is going to basically consequently increase because of this problem. So our PCO2 increased by 48. Okay, so we know our normal range is, let's say, around, we said 35 to 45. So because it increased, supposedly the amount of increase of the bicarb should be around 1 millimole. Okay, again, it differs because the normal range, but usually in acute compensation it's going to be around 24, and in chronic compensation it's going to be around 27. So because of this, we can identify that this is a chronic respiratory acidosis. Okay, I know it's a bit more complex, but I hope you guys get the gist of it. So your acute compensation for every 10 millimeters of mercury of CO2 is gonna change 1 millimeter of mercury of bicarb. Okay, however, in chronic, your kidneys are able to do a lot more, so within 2 to 3 days. So your bicarb is going to increase more to the higher range. So that's why in this case it's 27. So these are our respiratory things. Okay, so does this make sense for everyone? I know it's a bit more complex here, but we can take another example if it's still confusing. Just let me know. I can repeat it, or I can use another technique if you feel like you didn't understand it. You guys sure? Okay. Okay. Let's calculate it in another way. So PCO2 by 10. Okay, with every increase of CO2 by 10, which is acidosis, or decrease by alkalosis. تمام. So طيب. Okay, let me put it this way to make it easier. Okay, I'm going to erase this for now, guys, just so we can restart so that you understand it. Okay, our bicarb here is 27. So first we start off, we understood this is a primary respiratory acidosis. صح? This part is easy. What we tend to do in acid base is we usually take a middle number. For example, instead of between 35 to 45, for our calculations, we're going to take, let's say, 40. Tamam? So, okay. I'm just trying to think of an easier way to explain this for you guys. Okay. Let's understand one thing first. Okay. We know CO2 plus water is going to give us bicarb plus H plus, right? So essentially, in this case, if it's a primary respiratory acidosis, CO2 is up. What's going to happen as a consequence? It's going to shift this side. What's that going to do? It's going to increase H plus. That's why we're in acidosis. Okay. In order to compensate, okay, what we're going to do is the body, the kidneys are going to increase the amount of bicarb. Tamam? So this is increased to compensate. Because when you have more bicarb, it's going to start to shift away from the acidotic state. So you're going to become more alkalotic. At baseline, does this make sense for everyone? Just the equation. Yes. Okay. حلو. Perfect. Okay. طيب. Shahad, for the thing you sent me, he starts from 24 at baseline, صح? What does he start from at baseline? Okay, fair enough. طيب, what you guys might find easier is Shahad told me that the doctor uses a trick with you guys. Okay, and he says the following. He says acute. It's a graph. تمام. عندكم acute. عندكم chronic. Okay. Acute and chronic. Okay. This is at baseline. And then you're gonna have acidosis. And you're gonna have alkalosis. Okay. So here it's going to increase by 1 point. Here it's going to increase by 2. Here you're going to increase by 3. And here you're going to increase by, or here you're going to decrease, drop by 4 to 4.5. Okay. So this is how we're looking at the compensation. Okay. So again, with every increase in CO2 or PCO2 by 10, you're going to have, or any decrease in PCO2. So this is acidosis, this is alkalosis. Okay. You're going to have a change in bicarb, depending on if it's acute or if it's chronic. تمام? Our baseline in bicarb is always going to be 24. Okay, are you guys following with me until now? So if we know our baseline or midline in bicarb is 24, okay, our patient's bicarb is 27. Tamam? 27 is higher than 24 by 3 points. So that indicates that the bicarb has increased. Okay, so the bicarb has increased in order to compensate. Now, is this chronic compensation or is this acute compensation? Tamam? It's chronic compensation because it has increased this much. يعني طلع من 24, or it increased from 24 all the way up to 27. Okay, so that tells us that the kidneys have started to generate more bicarb. Okay, so it's a chronic compensation of a respiratory acidosis. Okay, does this make sense for everyone? I hope this made it easier with this. Okay, great. So let's say if instead the bicarb was, let's say it was 25, still within the normal range, but that would tell us that this is more of an acute compensation, not a chronic compensation. Do you see the difference? And same thing inversely for alkalosis, but just keep in mind, they will tend to ask you more about acidosis than they will about alkalosis in general. Tamam? Inshallah, that was simpler. I want to give you guys, ما أبغى أطول عليكم. So whoever has to go, like I gave you the primary gist of everything. I just want to give you one more case to make sure that you understand. Okay. I keep adding it from my laptop, so I'm not sure why it's loading, why it isn't loading. But what I can do is I can just write it. Okay. So if you have, wait, keep this version. There you go. Okay, perfect. Worked. Like, I can keep practicing with you guys as much as you need. Okay. As much as you need, but I just want to do this for now. Okay. So 22-year-old female with type 1 diabetes, that's important, presents to the ER with 1-day history of nausea, vomiting, polyuria, polydipsia, and abdominal pain. Okay. Physical exam reveals deep breathing and orthostatic dry mucous membranes and orthostatic hypotension. Sodium is 132. Is that high or is that low? You guys just tell me already in the chat, easy. Remember, our normal is 135 to 145. Okay, so our sodium is low. Okay. Our potassium. Okay. Our sodium is low. Our potassium is 6. Is that high or is that low? Remember, normal potassium is 3.5 to 5. High. Okay, wonderful. Chloride is 93, which is low. And bicarb is 11. Bicarb is very low, صح? If our normal is like to 20, 11 is really low bicarb. Okay, glucose is 720, which is extremely high. Okay, BUN is high, creatinine is very high. Okay, now let's keep the urinalysis to the side. pH is 7.27. Is that high or is that low? Low. So this is an acidosis. And we said bicarb on ABGs was 10, which is also low. And PCO2 is 23, which is also low. Okay, so now all of these are low. Which two are in a compatible direction for a metabolic problem? pH and bicarb. So this tells us this is a first disorder is we have a primary metabolic acidosis, right? So primary metabolic acidosis. Why? Because patient presents DKA, nausea, vomiting, very high glucose levels, acidosis. We suspect diabetic ketoacidosis, even though the urinary ketones are negative. Usually you have to remeasure them. So if this is a primary metabolic acidosis, that's the first thing, right? We looked at the patient's symptoms, we determined the pH, then we looked at the signs. Now, what we need to do is, again, we need to use Winter's formula. So we need to know, is the compensation appropriate or not? Is there a secondary disorder or is there no secondary disorder? Okay, so Winter's formula, we know is 1.5 times bicarb. What is bicarb? Usually the one in the ABG is better, 10. Okay, and then plus 8 plus minus 2. So that's just 15 plus 8, which is going to be 24 plus minus 2. Okay, so is our PCO2 within that range of 28 plus minus 2? 24 plus minus 2. Okay, great. So is the compensation appropriate? The answer is also yes. Perfect, you guys. Okay. So again, كده we answered compensation is appropriate. So there's no secondary disorder. We already know that from the history, because it's type 1 diabetes, DKA, it's an anion gap metabolic acidosis. But for the sake of you guys practicing, let's calculate the anion gap anyway. Okay. So to calculate the anion gap, we know it's going to be our sodium, okay, plus bicarb. Sorry, not plus. My bad. Sodium minus bicarb plus chloride. My mistake. Bicarb plus chloride. And already from the labs, we know that chloride is low, صح? We said chloride is low, and we said in a non-anion gap, chloride is supposed to increase. So without even doing the labs, you can start to see that, okay, I understand that this is a anion gap metabolic acidosis. Again, we'll calculate it for the sake of you guys practicing. So sodium is 132 minus our bicarb, again, let's use this one, is 10 plus 93. Okay, so 132 minus 103, which is going to be 129. 129. Ignore this. Okay. So anion gap is obviously greater than 12, صح? Okay. So because the anion gap is greater than 12, that means this is a anion gap metabolic acidosis, صح? Although, without calculating, we already knew that. Why? Because it's a case of DKA, because the chloride is low, because the anions are high. So if you go back to, I'm just going to open this file so you guys can see it again. If you go back to the mnemonic of mud piles, your anion gap is greater than 12, yes. But you know this is a case of diabetic ketoacidosis. So without going through the trouble of calculating everything, you already know that it's that, okay? And to be honest, for the sake of, you don't really need it as much. Sorry, I'm not going to do the delta for you guys because I think it's going to confuse you a lot and they're not really going to ask about it. But for now, with everything that we did, so we can recap. I'm going to actually open this because it's much better for recap. Okay, in terms of acid base, we first look at the patient's presenting symptoms. Tamam. Then we look at the ABG, pH. Is the patient acidotic, alkalotic, or normal? Okay. Then we look at PCO2 and bicarb, and we look at the direction. Remember, respiratory, they're the opposite, and metabolic, they're equal. So here in respiratory, you're going to have low pH, high PCO2. In respiratory alkalosis, high pH, low PCO2. Okay, and if you ever get lost in terms of compensation, just remember this formula here. Okay, this is the basics that are going to help you understand everything and the shifts to the left and the compensation and all that. Okay, for respiratory compensation, what you guys can use is, I'm going to like draw it out for you here. I'll do it like this. Okay. The trick that the doctor gave you will probably be more helpful than you like remembering the other stuff. So here you have acute, here you have chronic, here is acid. I'm just going to write alk. Okay. Here you have 1, here you have 2, here you have 3, here you have 4, slash 4.5. Drop. Tamam. And the baseline of your bicarb is 24. So for every 10 millimeters of mercury increase or decrease in your PCO2. So if it's an increase, that means we know it's a primary acidosis. So acute compensation should be 1 increase in bicarb. Chronic compensation should be 3 increase in bicarb. Tamam. And vice versa for alkalosis. Okay, so here your bicarb should decrease by 2. Here your bicarb should decrease by 4 to 5. Tamam. And that's all due to the way the kidneys are compensating. All right, so this is again just to recap everything that we talked about. If it's a metabolic problem, then you're going to calculate the respiratory compensation using Winter's formula. All right, which is 1.5 times bicarb plus 8 plus minus 2. And anything within this range is considered appropriate compensation. Whether it's inappropriate compensation, it's going to be as follows. Let's say your compensation is inappropriate and your CO2 is way too high. Then that tells you there's a secondary respiratory acidosis. Okay. Vice versa. If, let's say, the compensation of a metabolic acidosis is inadequate and CO2 is very low, then you know there's a secondary respiratory alkalosis. Okay, and vice versa, just so you guys understand how that works. Tamam. Now, for metabolic acidosis, you will always calculate the anion gap. So anion gap is sodium plus chloride plus sodium minus chloride plus bicarb. So this sodium minus the sum of chloride and bicarb. So normal is usually 12, less than 12. If it's plus minus 4, that's usually the range. So if your anion gap is high, meaning it's greater than 12, what does that mean? Well, that means that you have an unmeasured anion that's increasing in order to compensate for what you guys don't have here. Okay, the mnemonic, once you know if it's anion gap or non-anion gap, is either mud piles for anion gap, hard ass for non-anion gap. The delta, I don't want to get into right now because it's going to take a lot of time and I'm concerned that it's going to confuse you guys more. If you do want me to add on anything, I am more than happy to just record a short video and send it your way. So please let me know. So this is, again, a beautiful algorithm to show you everything. Check the pH, determine acid base, and the rest is history. So if you guys have any questions, I'm here for as long as you need me. I know it has been a very long session, but it is a very dense lecture. So genuinely, any question you have, I will stay till 11 if you need me to. I just want to really make sure that you guys understand this thoroughly and properly, because I know acid base is very difficult. And I hope this made it easier, or at least you have a clear algorithm in your head of how to approach this. It's not as difficult as it may seem when you look at the questions they ask you in the final exam. So I hope that's, any consolation. Okay, the point of the delta is basically, wait, I'll do it here, is to look at the ratio of compensation. So when you calculate the change in the anion gap based on the normal, how big it is, and the change in the bicarb, it kind of allows you to know if there are specific cases where you can have at the same time an anion gap metabolic acidosis, okay? And then you can have a secondary problem, okay? Or you can have, I know it sounds crazy, but like sometimes you can have a primary metabolic acidosis, and you can have a secondary metabolic alkalosis, which is like, what? That doesn't make sense. Or you can have a metabolic acidosis and then a pre-existing respiratory acidosis. It's a very complex thing. That's why I tried to simplify it. So it determines whether or not it's a mixed disorder. Because sometimes, مثلا, you will have bicarb that's very high, or actually, let's say bicarb that's very low. So it's okay, acidosis, or there's a problem, but your CO2 is also very, very low, مثلا. Okay, so you have, let's say, a primary metabolic acidosis, and then a secondary respiratory alkalosis. But when you look at the ABGs, the pH is normal, which is very weird. So like they rule each other out, which makes the pH in the middle. So it's a very complex and deep thing. فحسيت إنه صراحة you guys don't really have to get into it. But this ratio allows you to understand it better. You don't necessarily need it, بس يعني if you guys want me to keep going, I'm more than happy to. I want to just search one thing for you. Wait, I'll write it here. But genuinely, guys, عندكم أي سؤال? Don't be shy. Like, ask me whatever question you want. الله يسعدكم, الله يوفقكم يا رب, إن شاء الله it becomes like, it's a great exam, and don't stress about it too much. If you want, I can specifically solve questions from past exams, if you want me to. يعني like, if you want. My batch or other batches, predominant, okay. Like, for example, just آخر شيء عشان ضميري عشانكم. If we go back to acid-base practice questions, if I give you a case, مثلا 59-year-old male with a 35-pack-year smoking history, okay, he presents with shortness of breath, nausea, vomiting, and confusion, okay. Serum electrolytes show pH, okay, pH equals 7.19. PCO2, عادي ترى, if you want to leave, like, don't feel obliged to stay. PCO2 is 66, okay, and bicarb is 22, okay. Sodium is, oh, okay, مثلا, okay, interesting, never mind. They gave you the anion gap. They told you anion gap equals 16. Tamam, you didn't have to calculate it. What is correct about this patient's presentation? طيب, pH is low. تمام. PCO2 is high. صح? bicarb is normal. Okay, anion gap is like slightly increased, but or okay, they said normal in this question is, that's weird. Okay, they said normal is 12 to 20. I don't know why, بس هم كتبوا كده. We know this is an acidosis مثلا. We know this is increased, so we know it's a respiratory acidosis because they're opposite. صح? So the answer to this question is yes. So this patient has a primary respiratory acidosis. Okay, if you want to do the whole like compensation thing, it's not really going to apply because the bicarb hasn't increased. So you can say that like there's no proper compensation by the kidneys. But again, the whole concept here is that you're able to identify what is the main underlying disorder that this patient has. Okay, but yeah, you guys are right, like respiratory acidosis due to smoking history. Again, if you guys have any questions, literally anything, my email is listed in the beginning of the slides. If there's anything that's difficult, there's any question you have, anything you want me to do to help, موجودة دايما to help you guys. So just let me know and have a wonderful, wonderful night. الله يوفقكم وييسر أمركم. Again, yeah, anything you need, just let me know, all right? Got you. And thank you for the LGD notes, Shahad. They were very helpful. I looked through them to get everything. Oh, okay. I forgot I have to stop sharing. خلاص? Everyone good, inshallah?